This is the end of the diagnostic part of this course, or understanding what's happening to your clients, analyzing their experiences, and eventually diagnosing and treating what's going on for them. This is one of the most important diagnostic evaluations you will make with your clients, or whether or not they are anxious, depressed, or both, as well as the differences between generalized and situational experiences. So many people, echoed firmly in the media, term almost everybody with emotional difficulties as depressed, but that simply is not the case. Yes, many people are clearly depressed, but many more people are actually anxious. They don't know it and they think they are depressed. And most other people who observe and diagnose them, especially medical practitioners like PCPs, tell them they are depressed. But finally, many, if not most people, have symptoms of both anxiety and depression of one type or the other. Your job as an expert clinician is to understand exactly what is going on for your clients. As a psychiatrist emphasized to me soon after I graduated from our MSW program, the best diagnosis drives the best treatment. When you know all of this well and you make the right call or the best diagnosis, you will be incredibly effective. I use all of this every day, every hour, with every client for the same purposes. So, with that in mind, let's talk about differential diagnostics. Going back to what we talked about earlier about primary emotions and clinical experiences, people experience, all humans, joy, what we call in our profession wellness, fear, what we call anxiety, anger, what we call irritability, as well as sadness, or what we call depression. Also, you want to remember this slide, which is about the DSM-5, and we have diagnoses that relate to these as well. Or fear are the anxiety disorders, sadness, these depressive disorders, as well as anger, the impulsive and conduct disorders. We have diagnoses that do relate clearly to primary emotions. Now we want to talk about situational versus generalized experiences, or situational versus generalized anxiety and depression. We're starting off here with situational anxiety and what that is and what the diagnoses are that relate to them. Situational anxieties relate to specifically situations, places, or people, just situationally. It is a high survival fear response, but it is not continuous. It's a very high fear response in certain situations, but it's not continuous, or of course it's situational. Clearly, we have some right off the bat, like social anxiety, separation anxiety, and specific phobias. We also have post-traumatic stress disorder, which people really don't realize, and we want to help them realize, relates to an event. It's a situational thing, but it's huge and it can dominate their life afterwards, usually does, but it's still situational and not generalized. This also causes avoidance or disproportionate responses. And I'll just say, like, I have a healthy fear of snakes. It's just a slithering. It's wow. Anyway, so if I'm out gardening and stuff and I see a snake, I just have this huge disproportionate fear response. It's not going to hurt me. Doesn't matter. That's what I believe. And it's just, then I'm going to avoid that part of the garden or something if I can, because I don't want to see that snake again. So that's a very, very, very small example of avoidance and disproportionate response to our situational anxieties, whatever they may be. This person here, obviously, her situational fear is public speaking. It's absolutely, she's freaking it, which is most people. Most people just, there's like a survey once, they don't want to die and they don't want to speak publicly. That's number one. Number two, it's a huge fear response to just speaking anywhere publicly. This, as you may have already guessed, this is not Big Amy. Big Amy does not look like this. Big Amy is a generalized anxiety we'll talk about next. This is situational. There are situations, people, places, all sorts of things that cause a huge fear response. This is situational, not big Amy. The amygdala has not changed at all. Diagnostically, we do have these in the DSM very clearly. Separation anxiety disorder of a child with their parent. They may be otherwise feeling fine, but separation anxiety, they clearly experience. Social anxiety, again, any social situation, like person is feeling fine, not anxious, but there are certain social situations they just cannot do or like try to avoid them and they get really, really anxious for. A phobia, like I talked about, snakes, heights, you name it, we all have phobias, or most of us do, and that is situational. Agoraphobia is interesting because it's, oops, went back to the wrong one there. Agoraphobia is fear of open places, but I tend to think that people with generalized anxiety disorder, they're feeling that just agoraphobia alone. I've never seen that. Like a person does not feel any anxiety, but then they do in open places. I literally have never seen that. Doesn't mean it doesn't happen, but anyway. Oh God, I did it again. Panic disorder um, is something that people experience. Humans are the only animals that do it. Humans experience this because we um, we have fear of fear. It's a longer issue. It's a separate class almost. I can't get into it here, but it is situational fear, typically in response to generalized fear. Um, happens over time. Longer story, but that is situational. Also, very treatable, but very, very challenging if it isn't like life-changing, not good. PTSD, like we talked about. I won't go into that again. Those are all clinical diagnoses we have for situational anxiety or anxieties, plural. All right, now we're going to talk about generalized anxiety, really important part of this class, generalized anxiety. And these are the symptoms that you're looking for. It's more than just nervous or temporarily afraid. It's more than that. It's a high survival fear response and it's continuous. It may fluctuate in the amount of highness, so to speak, but it's always there. It's always on. That is generalized anxiety. A person may feel and show that they're shut down. They don't want to be around other people. They're paranoid of going out and socially afraid. It's just like, I don't want to be out. I don't want to be about. I just want to stay home. I just want to stay home. I don't want to go to school. I don't want to go to my job. Just like that is the experience. And it's not depressed. It's not a sadness. It's a fear. It's constant, constant fear. And it does not relate specifically to situations, places, or people. It's just always, always there. And importantly, this can look like, or the report to you from the client can look like depression, but it isn't. So a flat affect is certainly can be depression, but also can be just this continuous fear, just like deer in the headlights. It's literally a fear response of a deer. It really isn't, a generalized anxiety. But anyway, that's what that can be. Flat affect is that. So fetal, like mammals have a fear response when being attacked by another animal that wants to eat it is by getting all fetal. And so when someone says they're in their bedroom and they're fetal, that is not depression. In their bedroom and depressed is just kind of laying there. Fetal is a fear response. And then, of course, withdrawn. Don't want to be with people. It's way too more anxiety provoking to be with people, unless maybe it's your immediate family or someone like that. So, as you may guess, this is Big Amy. This absolutely is Big Amy, a larger, hyperreactive amygdala. This is what this feels like. Again, toxic stress will grow it to this size and the amount of activity level, but a Big Amy is like, I am just like more anxious all the time. And then it can get bigger with certain situations on top of that, but I am just, generally speaking, anxious. And of course, understandably, we have a diagnosis for this, thankfully, generalized anxiety disorder. So only time I ever diagnose someone with GAD, which is a lot. It is the most common thing that I diagnose is GAD because it is the most common thing that I see. Now that I know it, it is the most common thing that I see. So we have this one diagnosis. Instead of like situational, we have several diagnoses, but with a Big Amy GADA, call it, or Big Amy GA. So when I'm talking to clients, I'm talking about Big Amy, and that's big Amy GA I'm talking about, they get to know that really well. They know exactly what that is, or what it was after treatment. It's gone by. It's been treated. It is gone. It's gone. All right. So situational, generalized, or both. And this is important because um, a lot of people have both going on. They come to you, they have general anxiety going on, it's just always anxious, and they have situations that make them terrified. So it depends on what they're doing in their day. Even coming to your office can be terrifying, and you got to respect that and know that, know what you're looking for. But situational can be just situational. It can be mostly generalized with some situational. But again, a lot of people have experienced toxic stress. So they have a big Amy, it's generalized anxiety. And then they have experienced traumas. And so you have situational things on top of that. And together, of course, is extremely challenging, but it's extremely treatable. Extremely. And that's, of course, what this class is all about. Now we're going to move on to depression, the situational depression versus generalized depression. So with situational depression, it is the most common thing that I see in terms of depression. The most common anxiety that I'm treating is generalized. The most common thing I'm seeing is situational. And so what you want to look for here in a situational depression, it's not just the blues or feeling down temporarily. It is more continuous, but not all the time. It is not all the time. So it is a deep sadness response or responses, or a person can feel very depressed sometimes in certain situations or in several situations. They have a deep sadness response. And it is a response to life situations, anything that just find really depressing. Like I was talking to someone recently and she's lonely. It's depressing to be lonely. Does not have generalized depression as I would diagnose that. It is a situational or comes and goes kind of depression. And it is not grief. If you lose someone you love, you're going into a deep sadness. It is not depression. It is deep grief. And with enough help and support and love in your life, that will get better. Now, it is typically, this kind of situational depression is typically with hopelessness. Like, basically, my life sucks and I have no hope it's going to get better. However, I would like to. And by the way, there are some days where I'm feeling pretty happy and I'm feeling more hopeful. So I'm pretty happy and I'm not depressed like I am a lot of the other times. So it can come and go. That's the key thing about situational depression like this. Both the deep sadness and the hopelessness can set in and things can change and it gets better. So that really is also what you're trying to treat with CBT, especially, is helping people and relationships, most importantly, healthy, caring relationships. In this situation, your client says, I don't really care, but I want to. Ugh, most of the time, I don't care, but I'd like to. It's that kind of perspective, that kind of depression. This is not small hippo. The hippocampus has not shrunken from toxic stress. It just hasn't. The person is depressed because they're not happy enough, like literally not enough joy. So there's so much more sadness. And with hopelessness on top of it, there's even more sadness because it ain't going to get better. But some days it does. So that's what you're looking for with situational depression. We have diagnoses for this. Obviously, major depressive disorder, the number one is my distinction because I'm talking about two types of major depressive disorder in this lecture. This is number one. Dysthymia is like a low-grade depression. And again, it's situational because it can come and go, but it's a low-grade thing. It can be something that basically sets in pretty solidly, but still, if a person has good days or they have a change in life circumstances, they feel better. And then disruptive mood dysregulation is something that we have diagnostically now for kids up to age 18. Those are all situational depression. Next, we go to generalized depression. This is a very rare condition. I don't see it very much, but it does happen after a long, long time of toxic stress and probably a lot of generalized anxiety before that. Probably. Can't really say all the time, but probably. This is what you're looking for generalized depression. Again, rare, but this is what you're looking for. It's a full experience of apathy, vapidness, just vapid and empty, just full, just a full experience of that. It's continuous. It never lets up. It never changes. A good day does not change the mood. The mood is just low. In fact, it's just flat. It's empty. This is blunted emotional responses. And I mean all responses. There's no joy, there's no fear, there's no sadness, there's no anger. It's just none of that is going on. It is blunted emotional responses. It's also what we call anhedonia or loss of pleasure. No pleasure in anything. Just no pleasure. Just not happening. It's also, if your client ever says this to you, I don't care that I don't care. I don't feel anything. So, the other kind of depression is like, I don't care, but I'd like to care. I'd like it to get better. This is like, I don't care. Just don't care. That's what you're looking at with generalized depression. This is, without question, small hippo. This is absolutely small, atrophied, shrunken hippocampus. It is blunted emotional responses, all responses. It's just flat, empty, vapid, nothing. And of course, we have this diagnosis. And again, number 2 is my distinction. The first one is situational. The second one is generalized depression, or this one. Now, what you want to be looking for when you're looking at depression, is it like that deep sadness thing, or is it emptiness? And they are separate conditions. Again, one is deep sadness with hopelessness, and that can change, and it does change. And the other is stress system blunting. It ain't going to change without treatment, typically a serotonin medication, by the way. It is hippocampal atrophy. That's what that is. This slide, we looked at it before. I want to emphasize this again by the people doing this research, that note experience of chronic stress, not trauma. That's not true, in my opinion. May lead to stress system blunting. They really should have an arrow from the hippocampal volume decrease box on the right over to this one, because that's what happens. That hippocampus shrinks and a person has stress system blunting. There's no feeling anywhere. And it is advantageous through evolution, because at some point you just can't feel that kind of fear anymore. It's going to break your body down. So the hippocampus just stops the whole thing. And if you're, of course, living in a group of other humans, they're going to help you care for yourself and get to the other side of all this, like we do as clinicians. Next, moving into, is it depression? Is it emptiness? Is it anxiety? Is it situational? Generalized, all this stuff. So that's what we call a differential diagnosis. That's what we're doing here. That's what you'll be doing the rest of your career, is a differential diagnosis. And there are tools for understanding what's actually happening, what understanding your client's emotional experiences. It's your observation, it's your full history, but it's also tools. And they're in the module. They're right there. All of these are in the module for you to look at and see and understand. There's the overall anxiety severity and impairment scale, the overall depression severity and impairment scale, the Hamilton anxiety and depression rating scales, as well as the next two are really popular, used by a lot of doctors especially and clinicians. The patient health questionnaire, the PHQ-9, or the generalized anxiety disorder, GAD-7. You will see this a lot. They're really good. Recommend all of these. And there's also a calculator in the module too that you can try out. But you'll see this. You want to use 2 of these in your discussion post, on your diagnostic discussion post for this module. But these are rating scales that can be very helpful to you in your differential diagnoses. This slide is something that I wish I could spend more time on because it's important, but really, really focus on this. And that is, can a client have a bigger AMI? Not a big or huge one, but a bigger one? Yes, they can. Like, they're pretty high functioning, and you can tell there's some sort of like bigger AMI thing going on. There's some amount of generalized anxiety, but they keep going, keep going, keep going. And you can help them with treatment, which may or may not include medication, maybe other treatments like mindfulness and stress reduction, and a lot of caring, loving relationships that can shrink the bigger AMI. And then, can a person have a smaller hippo? Yes, they can. And I think a lot of people with a big AMI for a long time can have a smaller hippo, maybe not a really small one, but a smaller one. And what you notice is like flatness, kind of really not kind of caring very much, but kind of caring. just kind of like a smaller hippo thing. And again, serotonin medications can help with that, or the treatments that you talk about with your client and their caring and healthy relationships can help with that too. But just remember that there is such a thing as a bigger Amy, there is such a thing as a smaller hippo, and you want to diagnose those as well. Chemical disorders, question mark. Yeah, nope. There's just that chemical imbalance hypothesis I've told you before. There's just no evidence I've seen that there's something wrong with brain chemistry. I've never seen that. It just, and doctors told me that a long time ago, and we just don't have evidence for it. So, like I've emphasized so many times in this class, it's a structural and connection problem or change, actually. The amygdala, for biological reasons, is hyperresponsive, and the hippocampus and the prefrontal cortex have atrophied again for advantage. And in this situation, the amygdala hyperreacts, that's generalized anxiety disorder, and the PFC cannot do its job or regulate emotions, and the hippocampus shrinks and blunts emotions again for a purpose. And by the way, I've never seen anywhere that like a serotonin medication changes the PFC or the prefrontal cortex. I've never seen that. It's like basically if we shrink the big Amy and grow the small hippo, the PFC problem just goes away. There are other things that can be very effective for a PFC that just isn't doing its job, but usually this is what I'm focusing on, a big Amy or a small hippo. The next thing I want to say is about anxiety, depression, and irritability, or fear, sadness, and anger responses. So the anger response, it's so important to know this, and that is typically tied to anxiety and or depression. Then it's usually a secondary response, and not like minutes later, it could be, or just a fraction of a second later. It's like when someone is really anxious, they seem to be on edge. They get angry so quickly. And it's because the anger response is all tied up in the amygdala, all tied up in like survival, all tied up in a quick response to a situation. Anger response is important because, like, if you're getting attacked by a wild animal back in the day, or even now, you have a fear response, and the fight or flight, the fight is fueled by the anger emotion. You got to have an anger emotion to fight back. So that's why it exists. But someone who's like depressed can be like really down and out, and then something happens, and they get really angry because anger sort of follows that as well. So just clients don't talk about their anger response typically. It's kind of shameful to like say, I get really angry at people or other things. But you can ask them questions over time, like, how's your patience? Do you get kind of grumpy? This and that. You can find out that, yeah, they have a bigger anger response at times that goes along with anxiety and or depression. Now we're getting to the end of this lecture, and chemo brain. This is important, and there's an article in the module about this, that chemo brain is often talked about for people with getting chemotherapy, and that is they feel like they don't remember well, they don't learn well, and they're kind of flat. And there's a theory out there, which I subscribe to, that that chemotherapy, of course, stops new cell growth, which stops neurogenesis in the hippocampus, which then can lead to I don't think well, I don't remember well, and I'm really flat in my emotions, or what people would call depressed typically. And a lot of doctors prescribe an antidepressant or a serotonin medication to help with that, and it works. So that's something for you to be really knowledgeable about with your clients. If they're experiencing this chemo brain idea, know what that is, and you can recommend to them to talk to their doctors if they want to about that particular treatment while they're getting chemotherapy. And then the other thing that's in your module also is postpartum difficulties. So the idea here is like, because you know that from this class that a lot of cortisol continuously in the system will grow the amygdala and shrink the hippocampus. So during pregnancy, there's a lot of cortisol going on. I actually don't know why. But anyway, there's a lot of cortisol in the system during pregnancy. And I'm just like hypothesized that someone with a bigger Amy or a smaller hippo is more susceptible to a huge Amy or a really small hippo. So I wonder about that, and I also observe that doctors will prescribe serotonin medications or antidepressants, and women get better. So that's something to also know about. Just be watching your clients who are pregnant or after they've given birth, and you can recommend they talk to their doctors if they want to. All right, last slide here, and getting back to the birds. The nicknames that mean everything in this class to help you remember if you want to use them with your clients: Big Amy, Small Hippo. That's just to help you understand what we're talking about in every lecture, every class. Big Amy, Small Hippo, how that happens and how we treat it, which is coming up very, very soon. Okay, until the next lecture, take good care.